welcome to all of you. My name is Kyle Christiason. My pronouns are he, him, his, and it's really a joy to be with you today. So thank you for your time today, and I hope we have a great discussion and conversation. So let's launch if we could, Nick. Here we go. Perfect. Good. Well, again, good day to all of you. I'm really grateful for this opportunity to share our story with you. And it is the story of our family's journey and how it has led to some of the most meaningful practice of medicine I have ever done. I'm also really grateful to IBMF for leading this ongoing national discussion on trust. Trust, I think we all know, is just so complicated, and the constituencies of this trust relationship ever appear to be endless, it seems. So in the discussion today, I will try to highlight some of the trust vulnerabilities between patients and healthcare, between patients and physicians, providers, and I think even between physicians, providers, and our careers. I really look forward to learning from you all as well, and hopefully we have some time together where we can do some of that at the end. And so now that we are all friends, I'd like to give you a little update on our family. Next slide. When our first child was born, a dear friend who is an artist made us this full-length mirror to place on the wall in our child's room. Our friend was an artist in stained glass, so you can imagine this big mirror was framed by all this incredible, beautiful stained glass art. My wife and I would regularly dance with our new baby in our arms, dreaming about their future, all while looking into this full-length mirror. And as our children grew, they loved to play dress up with their many friends, always, you can see this, right? Checking themselves in this full-length mirror. So when in 6th grade, our child requested I take down this full body mirror in their bedroom, I was confused and more than a little sad to see this fixture come down. And in its place, our child wanted me to hang a tiny 3-inch by 3-inch mirror, the size of a postcard. And it was just large enough to see one's eyes, but absolutely nothing else. What we didn't know yet, and certainly didn't understand yet, was that this mirror had become dangerous to our child's health. And although our child was not yet equipped with terminology, our child was experiencing gender dysphoria. You see, our child was sex assigned female at birth, but was increasingly aware of their gender identification as masculine. So when our child looked into this full body mirror, they would see body parts that were incongruous with their gender identity. For example, when he saw his chest, he saw something in stark contrast to what he knew to be true in his mind. He was not supposed to have breasts. And when they started having menstrual period, their entire being is screaming, what is going on? Our child would feel intense depression and despair when catching a glimpse of their body in the mirror while just toweling off after a shower. This mirror had once been a source of joy in our home, but little did we know at the time it had become a serious part of our child planning their own death by suicide. Go to the next slide, please. So Ben, not our child's name at birth, had been this most joy-filled young child. We loved our child's tomboy expressions. They had very stereotypical masculine play as a young child, always wanted ninja stuff for Christmas. But in respect, our child had become more serious around the age of 5. We explained it away as a child who was soulful or wisdom beyond their years, that sort of thing. And only looking back do we understand that our child was experiencing early depression and gender dysphoria. When our child came out in 6th grade as lesbian, we thought surely this must be the source of what looked like some previous sadness. But despite being affirmed by all immediate and extended family, they still did not seem happy. And later, they told us that he was under this impression that all lesbians felt like boys on the inside. And truly, Ben's diligence in searching the internet helped him discover his true and his authentic identity. Next slide. For it wasn't until Ben discovered this term, transgender, did his spark truly return. And it became our first really clear understanding of the differences between sexual orientation and gender identification. And if you have any questions about these and other separate identities, let's spend a moment on it during our Q&A. So when Ben understood and identified his authentic self as a boy, his joy and spark returned, just like we remembered when he was 3 and 4 years of age, before dysphoria truly set in. And of course, all of this coincides with natural development of our gender identity. Next slide. So friends, I need to share with you, though, this journey was not without its missteps as parents and loved ones. Here you can see our child rocking the Harry Potter theme as he did for like years. And in fact, during his really intense pretend play years, like around 3 to 5, he would only interact with us if we addressed him as Harry. And all that seemed well enough. It was perfectly normal developmental play, it really is. But age 3 to 4 years, he was playing with the new baby and their grandmother. And our child informed Grandma, "I'm going to be the best big brother." Of course, he was, quote, lovingly corrected. "No, honey, you're going to be the best big sister." And we recall a few such scenarios, but we're just convinced that we missed a truckload of opportunities to understand and support our child at an earlier age. The truth is, we didn't know what to look for or that we should even be looking. And even when Ben discovered the term transgender and knew himself to be masculine identity, his burden was still to try to come out to us as parents and family, to educate us, if you will, to even convince us. But even when we were on board, we discovered we were in for a rocky journey. Next slide. You see, we really felt quite alone in trying to support our child. As a physician, I looked back and I had very minimal training, if any. So I tried to find a physician colleague who specialized, and I couldn't find anything close. We queried our insurance company for advice. And of course, they kindly reminded me first to, quote, stay in network. That seemed fine. So they gave me a name of a counselor who was an hour and a half away and was a sex therapist. And although she professed to be fascinated by our child, Ben, she had not had any experience with any transgender clients. So we moved on to EAP counseling, and all that was really wonderful, very helpful, but still no previous transgender client experience. And like many folks, we felt alone and a bit on our own. That trust level was being challenged. We didn't feel that healthcare or that our team had our back. And you got to remember, this is a family with ridiculous privilege, and we couldn't feel like we could navigate it. So let's explore some of those disparities a little bit further. Next slide. Remember, there is no such thing as an LGBTQ or plus person. Each letter and all the others, they reflect individual, unique identities. Nevertheless, there can be this common experience of discrimination and need for resilience, if you will. But this is what rejection looks like in the data. 40% rejected by family, friends, your first tier of support. A third physically attacked. You can maybe double that for trans folks. 1 out of 5 treated unfairly by employer. And again, for trans folks, maybe half have actually had employment challenges due to identifying as trans. Kids, they're not feeling safe in school. So a third will regularly miss school when that's not a safe place. Next slide. I wish the data were better for those of us in healthcare. Unfortunately, it's not. Look at what these reported experiences have been identified. You refuse to touch me. You blame me for my health status. You treated me with harsh or abusive or judgmental language. Or at the bottom, 1 out of 5 trans folks flat out refused care. So sadly for our LGBTQ plus youth, that rejection begins even in the home. Parents may refuse to affirm their child. Parents may refuse them access to their affirming peers for extended family. And all too often, parental rejection includes kicking kids out of the house. Next slide. 40% of homeless youth identify as LGBTQ plus. Said another way, our kids are worrying about food and shelter. Again, that's just terrifying. If food and shelter is at risk, obviously there's low hope for kind of moving up that hierarchy of needs to achieve or hope for better wellness. So if your basic needs aren't being met, imagine how little interest you have in what your A1C is, or whether you're up to date on your immunizations or cancer screening. And next slide. So when food and shelter is at risk, our kids simply are not living their best selves. They're not developing well. They're at increased risk for substance use and more severe for increased risk for suicide. As mentioned with homelessness, that increases risk for survival sex and STI exposures and lots of other consequences and sequelae. Next slide. I'm going to orient you to this slide. This is a study of youth, trans youth in the light blue bars, and their cisgender peers in the dark blue bars. If we go left to right, you're looking at depression, anxiety, suicide ideation and attempt, self-harm, and just mental health access and services. And I think we can agree, it looks generally like 2 to 3 times increased risk across the board for trans kids for all of these. The slides from Fenway. So 2 to 3 times increased risk for trans youth compared to their cisgender peers for all of these factors. Next slide. Remember, our kids are living in this environment of discrimination. It took 5 minutes for me to grab all these headlines and place them on a slide. Imagine the vulnerability when your very existence is being publicly debated or even legislated. And during these sessions, we, in our clinics, see an uptick in depression, anxiety, suicide ideation. And that environment of politics is threatening our patients' health. But it is an opportunity, I think, for healthcare to help lead community conversations on these and many other pertinent topics impacting the wellness of all of our communities. And so hopefully this discussion on disparities helps at least set up our understanding of the why it was important for us to start a dedicated clinic. When health outcomes and experiences are different than expected, to us, it made sense to try something different. So let's talk about how that might translate these disparities into something of an action plan. Next slide. Unfortunately, there are innumerable biases impacting the wellness of our communities at most risk. People of color, immigrants, poverty, homelessness, incarcerated. In fact, we often celebrate the resilience of these communities, but I would ask that we think about, shouldn't we try to disrupt the status quo that routinely places these folks at more risk to begin with? And again, my challenge to all of us is let's not abdicate our role as scientists and as healers and leaders, which means we might need to assume more responsibility for other determinants of health. So how do we do this? I want to share 4 principles that we utilized in redesigning healthcare in one small clinic in Northeast Iowa. Next slide. So we're going to use this framework, this prescription for action, which again can be applicable to all inequity. But the 4 principles that we started with and always come back to: the art of noticing, that actually seeing the problems when they're there and stop ignoring them. This concept of commit to fix. Again, you may not know how, but you do know the why. So just start there. Commit to do something about it. This concept of power of small. Don't let perfection be the enemy of good. Just start where you are and go. And finally, we regularly engage in storytelling. We'll have a few examples of all these. Next slide. With regards to the art of noticing, at our clinic, we simply started with that acknowledgement of the absurdity of poor outcomes experienced by one part of our community, LGBTQ+. We stopped explaining it away as, oh, it's a mental health problem, or that's an academic medical center problem, or all the many ways that we blame poor outcomes on our patients. We do it all the time. And instead, we started with this noticing. Notice the gap in outcomes. Mind the gap, if you will, for those of you who have been to London and been in the tube. Mind the gap. Notice the gap. Incidentally, I first learned this principle from Dr. Berwick and IHI during the 100,000 Lives campaign. We accept preventable errors and infections as simply, quote, the cost of taking care of sick people. Well, we learned in 100,000 Lives campaign, that's not acceptable. Take the scales off our eyes and notice that we can do something about that. So this willful blindness idea can actively be changed if we're willing to practice it. And by the way, like everything else, if we practice it, we get better at it. So another example of noticing is capturing the voice of the folks that we were trying to serve. We always get into trouble when we make assumptions. And to avoid this, we started with lots of listening sessions. We engaged in person, online, at the university, lots of forum, and to try to just understand and ask the question regularly. If from the ground up, we could create a new clinic to serve LGBTQ folks, what would that look like? What would be ideal? Tell us your past experiences. What would you like to make it look like now? And so that's how we started. And finally, the platinum rule, in this spirit of avoiding making assumptions. We love the platinum rule. Have you all heard of this? Most of us know this, the golden rule, right? That is to treat others the way you would want to be treated. Aha. Again, to me, it sounds like we're making an assumption. So instead, we strive toward the platinum rule. That is, treat others the way they want to be treated. One word reframes everything for us. Next slide. Principle number 2, this concept of commit to fix. So once we're aware of the gaps in outcome, I don't have it in front of me, but there's a quote, something along the line of the cost of noticing is that, well, now you can't unsee that. And now you have responsibility for it. So let's continue the act of noticing, but once we're aware of those gaps and outcomes and recognize that when we treat people in similar manner and we get different outcomes, we have to do something different. So the next step is commit to fix it. And this is simple and profound at the same time. We can feel super overwhelmed and really even afraid of that. But there's such power in taking that simple step of just committing to doing something. And again, it comes back to, you don't have to know how, you just have to be aware of the why. And we kept on noticing during our journey with Ben that, and patients we were noticing going 2, 3, 5, 6 hours away to get culturally humble care, we kept on saying somebody ought to do something about this. And again, so listen for that nudge for yourself. Are you getting that nudge that, gosh, this is the right thing? Somebody should do something. Again, that might be just the nudge that you're looking for. Next slide. Principle number 3, this concept of the power of small. So the power of small, to me, is this liberating follow-up to the second principle, committing to fix. As overwhelming as that commitment can feel, it's equally comforting to me to know that every small step towards improvement is meaningful. So this concept includes things like this continuous improvement process. The power of small is an example of simply starting just right where you are. No need to create massive bureaucracy. When we do that, at risk is attempting to make it perfect on day one. Never happens. At risk is this compulsion to get uniform consensus on absolutely everything from everyone. Again, never going to happen. So start where you are and go. As an example, our clinic embeds really robust huddling, during which we review the most recent improvement process that we created. Did it work? Did we have to tweak it, modify it? But we actively ask, what are the new barriers you found to a better experience? And we put that lens on, and we teach our team to use that lens and look and notice for inefficiencies, bad experiences. Then they find them. So every team member actively owns this process to improve the experience every day. We try an improvement and we come back and reassess in a week or 2 or 3. Is life better or not? And then we keep on going. It keeps us and helps us to stop doing stupid stuff. You know what I'm talking about, the stuff we do that we know doesn't add value, but we do it. This is that process. A nurse recognized the order for documenting vitals was different on the intake form than in the electronic health record. Tiny, but still a moment for inefficiency and error. And it was easy to fix. And this nurse knew they had improved the lives of their team members. When you practice this, that flywheel just takes off. Finally, for power of small, we're obsessed with key moments, often overlooked as inconsequential. These are moments for making or breaking a good experience. And key moments might include that very first phone call into our clinic when we ask, what name and what pronouns would you like us to use for you? When that has never happened in healthcare for someone who identifies as trans, it is utterly affirming. Key moments might be the moment when a patient's checking in and our team knows how to prevent that potential pitfall of a patient checking in under a gender affirming name and not their legal name, which might not be gender affirming. How do you avoid that pitfall? How do you avoid that discomfort and awkward? It might be a physician or provider walking into the exam room and introducing themselves with pronouns. Each of these might seem small or even trivial, but our philosophy is that each of these can create a tiny good memory, and you string together lots of good memories from a medical visit, and you start to create an overall good experience. We believe this mindset is essential to redesigning healthcare. Said another way, next slide. Don't leave a good experience to chance. Instead, design for it, make it happen, create it. Next slide. The fourth principle we use is storytelling. One of our favorite quotes is from Margolis. He says, if you want to learn about a culture, listen to the stories. And if you want to change the culture, then change the stories. And this has become a true north for us. We continue to be amazed by our patients. We find our purpose in hearing their stories. As caregivers, we're refilled when patients share their improved trust in healthcare in general through our clinic's experience and philosophies. And we purposefully share those stories at our huddles. In fact, we try to finish our busy day with these words of affirmation bouncing around in our hearts and our minds. And we think this is how we need to send our team members home at night. Already stressed out, but this is their mindset when they go home. already kind of helping get reconnected with their original purpose in medicine. It's our small antidote to burnout. Leaders need to also lead by example with storytelling. As leaders, you have the opportunity to become the best story gatherer you know in your organization. It can be very simple, simply like asking, tell me one thing you love about what you do, or what is just one thing someone did today to make you feel special? It's just that simple. Then hear those stories, become the best pollinator of those stories, spread them out across the organization. By modeling all of that, we as an organization, we become better noticers of opportunity for improvement, but also we become better connected with our original purpose in medicine. Again, this can help with burnout. My colleagues regularly say this clinic is their favorite 2 hours of medicine every week because I believe we're connecting them to those stories. Next slide. So launching our clinic, we started again listening, which led to our mission, our vision, our goals. We recruited critical team members for the LGBTQ clinic. That included pharmacy and lab, co-located with the team, really has been an essential part of our success. Every team member receives initial and ongoing sensitivity education. I encourage you to look at Safe Zones Project, which is an open source resource for education. We heard time and time and time again in our original sessions, educate yourself. Don't expect patients to come in and educate you about transgender health or other. We continue to have this constant obsession with those key moments because we believe that they are what can really make or break good experiences in care, including looking and awareness of those potential pitfalls. Think about checking in. If I'm checking in, expressing or presenting and using a chosen name that's not my legal name, how does the check-in team address that and make it a good experience for everyone? Clear, visible cues for inclusion. That includes posters and rainbow flag, or might be my pronouns on my name badge. Those are visible cues that we can see. Also, again, how we interact by introducing myself with pronouns. Those are all clues and cues to inclusion. And finally, always come back. We loop back to our mission, our vision, our goals. So I want to think about my child Ben's experience with dysphoria. And again, so severe in junior high was Ben's dysphoria, he had actively created a death by suicide plan. So to complement Ben's experience, I want to share just a bit more data that hopefully should give us some hope and spark us to maybe further action. Next slide. If not already familiar, I encourage you to get acquainted with the Trevor Project, which is the premier campaign for suicide awareness and prevention. But their research affirms that previously reported increased risk for suicide and suicide attempts for LGBTQ plus youth. But they also discovered the power of purposeful, clear, visible support. Remember those cues we just talked about. In fact, those cues, that support can be life-saving. So next slide. In 2019, Trevor Project found a 40% reduction in reported suicide attempts when LGBTQ youth were supported by an adult. Next slide. In other words, a single adult in a child's life using a child's chosen name or using appropriate pronouns can reduce the likelihood of suicide by 40%. Taking us back to our principles, simply following this platinum rule we discussed earlier, that can be life-saving. And by the way, that adult could be anyone, a nurse, a physician, of course, a teacher, a neighbor, a grandparent, an aunt or an uncle. In truth, it could be you. Next slide. Ben was the spark for our clinic, but there have been other sparks of opportunity as well. For example, we have a dedicated women's health clinic in our system. And when someone called in with a voice sounding as low as mine and asked for cervical cancer screening, a pap test, they were told they only see women. We discovered that this was a transmasculine person who still had a cervix and still needed cancer screening. But in that moment, a key moment, we had missed the opportunity to be affirming and provide really necessary care. All of this led to launching UnityPoint Health's first dedicated LGBTQ plus clinic in January of 2018. And we continue to learn how to improve and make our space safer and more welcoming for all folks. Next slide. Now, based on our listening sessions, we created this vision for a primary care clinic for LGBTQ plus. Although the majority of our care is gender affirming healthcare, including a lot of hormone therapy, we also take care of diabetes and heart failure and preventive care and vaccinations, etc. We feel having our co-located, our embedded pharmacy team, lab, and gender affirming voice therapy have also been very essential to our success and experience for patients and providers alike. Next slide. Our clinic is a dedicated physical space with all key team members 2 evenings per month to bring that whole team together. That's what we were able to organize. And since opening, we've had to expand our access more than 5-fold just to continue to meet demand. And we're now caring for more than 300 folks a year. So in addition to the physical clinic, we're really super proud of a good kind of contagious, sharing best practices and passion and education with our system. We've launched a second clinic in our system's largest urban setting in Des Moines. And we've provided basic LGBTQ plus education to our entire workforce of 30,000. In the effort to monitor satisfaction, we have a greater than 80% survey response rate and nearly 100% satisfaction. And we designed an immediate feedback survey with only 5 questions. However, the most important question we believe, which we've added now 3 or 4 years ago, is did we earn your trust today? With an option to add lots of detail. Now remember, we said never leave a good experience to chance. Instead, we want to design for it. And I think the same is true for trust. Let's move to the next slide. So here's a few steps to creating trust within the LGBTQ plus arena, in your life and in healthcare and in leadership. And by the way, you don't have to do another seminar. You don't have to go to CME. You don't have to do anything different. You can start these right now today. Educate yourself. We started that right now in the last hour. Way to go. Reflect on your own personal practices for inclusivity. Use non-gendered language. Think about all the ways we do that. Instead of saying he or she, use they. Instead of my waiter, say my server. Instead of my wife, say spouse. All the ways we use gendered language. Never make assumptions, always ask. And so we're not supposed to see gender identity. So when we want to be clear and honor that, we ask, can I ask what are your pronouns? What name would you like me to use to address you? Introduce yourself with pronouns. That, again, is one of the most profound cues that we've experienced in the last several years. When we do that as physicians, the experience for the patient is immediately started off well. Use pronouns on your email signature. Again, that invites clear support. That invites a conversation perhaps, but it's a big deal. Never be afraid to interrupt bias, disrespect, and harassment when you see it. That's our job. Next slide. So I want to introduce you a bit to my family. Ben is in the orange. and now living in and thriving in Chicago. He loves it. And younger son, Lars, on the left. And someone asked somewhere during this journey to our younger son, Lars, how would you describe all these changes in your sibling? And his answer was simple. He's the same, only happier. And that has resonated with us time and time again. And one of those just simple truths that our family has experienced, as well as what we see every single day in our office. So during our family's journey, we have experienced the full range of emotions, I can promise you. And we have failed as parents too many times, but we've also prevailed. And as a family, we did all that together. And constant through our entire journey is this truth, that our children are our children. We love them, period. But the same is and ought to be true for our patients. We, in healthcare, we have this maybe joyful duty to improve their experience of healthcare. Life's most meaningful milestones occur around experiences of healthcare. Imagine, oh, that happened before the diagnosis. No, that happened after the surgery. Those are the milestones that we put in life. So these events in healthcare, they're inevitable. However, our unique ability in healthcare to ease pain, distress, and fear, it's not inevitable. All too often, we do leave it to chance. So I encourage us to re-examine our role. Let's think about how we can redesign healthcare for the betterment of patients and providers alike. And we can earn trust and be a welcomed guest in the lives of our patients if we do so. Next slide. I want to finish with this discussion and tell a story about when we were huddling, as I mentioned before, at the close of clinic. We were gathered, sharing best practices of the day, what we learned, and some good stories. And a patient had come out of the room, noticed us gathering. This patient had been with us maybe 3 months. The beginning, their first visit, off the chart depression and anxiety scores. And now this visit tonight, almost negligible. The patient came out in tears and told us, gathered, I want you all to know something, that because you chose in healthcare for the first time in my 40 years, in healthcare, you chose to see me as my most authentic self. That's where you started. I want you all to know that since that happened, for the first time in 10 years, I don't think daily about ending my life. Simple, loving steps can make all the difference in the lives of our patients when we take accountability and responsibility for that, notice those opportunities, and together we can improve trust, not only with our patients, but within the caregiver community. So thank you so much for the opportunity to be here with you all. And I look forward to learning now together what your experiences have been and learning from you. And so I think we have maybe some time to have some conversation if you would like.
Yes, thank you so very much, Kyle, for sharing, just very bravely sharing your personal and professional self with all of us. We're very grateful and thank you for everything you do. I don't see any questions in chat for us to bounce to, so we can open it up to folks who are on the line. You can feel free to share thoughts, questions, or if you'd prefer to put those in the chat, feel free to do that.
Good question about why safe zones training over in-house training. And that's a great question. I actually bring those together. Safe zones is kind of a grab and go type of resource, open source, so no need to get approval or anything like that. And it's everything from a 5-minute nugget of education to a 4-hour, the whole team's going to dive in and really dig into bias understanding of our personal biases. And so you can choose by topic, you can choose based on the size of the group. And by the way, if you're afraid of moderating, it all comes with pre-equipped moderation tools. So it's really a wonderful resource. We again, all of our team members started with a presentation to us 5 years ago. We have continued to take that and modify it ourselves. And so yeah, we do it in-house now. And for whomever is ready and willing to listen, we'll do the presentation. So I think to date, we've done 80 to more than 2,500 people of these hour-long sessions within UniPoint Health. And so again, we've created our own based on feedback and our experiences, and that's right. So I think you blend those together. Do you see better health outcomes in your transgender youth because of lack of barriers to care? I want to make sure I address the question well. Without a doubt, we see youth, their health suffer when their most authentic self is not being recognized. But it's not just youth. That our youngest patient, I think, is about 6 right now. Our oldest patient's about 76. Across the entire spectrum, we have observed time and time and time again, when we do not pay attention to most authentic self, when we don't start with, for example, what is your name? What are your pronouns? When we don't address those, then the rest just doesn't matter. What we hear time and again is experiences of patients being told, listen, get your diabetes under control, get your blood pressure under control, lose the weight. Then we'll start talking about things like gender-affirming hormone therapy, or whether you're a candidate for gender-affirming surgical therapy or whatever else. And that is absolutely upside down. When we start with treating the individual, your most authentic core self, we'll see that fundamentally shift. All of a sudden, yes, I'm excited about my healthcare. I want to be engaged in my healthcare, and so we'll see all those conditions improve. But again, it's often been this reverse for many folks.
Thank you. So another question that popped up is, if a C-suite leader were listening in, what would be your first 2 pieces of advice or the first 2 steps you would suggest to make the organization more trustworthy for the LGBTQ+ community?
Yeah, great. And I hope so. And again, this, of course, needs leadership. One of the things that we found is we can have clinical engagement, but to take it to the top level, it does require C-suite leadership as well. So I think there's a couple ways I might think about this. One is there are guidelines out there, and what does it look like to become an affirming organization? So the Human Rights Campaign, HRC, has the Diversity Equity Index score. And this would be a great resource if you want to have something to target and shoot for. This is an annual recognition. The bar keeps getting set higher every year, as it ought to continue this continuous improvement. So that's a great thing to look at. Everything from how we take care of our own employees to how we show up for our patients and families and the community at whole. So those are all, again, those constituencies of trust that we've talked about time and time again. So that's a great way to think about metrics. If we're all very metric happy, if we're thinking about that. The other is we started DEI groups across UniPoint Health. I think many are doing that across the nation. And so that's been grassroots as well as led at the system level. So I think that's actually has been a great opportunity. And the most important thing I flew out of my head, so it'll come back.
Yes, definitely tell us if you want to return to that. A new question is, are there better outcomes if there's a separate LGBTQ+ clinic space versus integrating inclusive, welcoming strategies into general practice?
Awesome question. Again, very, very appropriately leading. Why do we have to have an individual clinic? I think this actually comes back to what I was going to say, not C-suite, but physicians specifically. And this is a great question along this line. Physicians regularly balk when we talk about treating populations or people, if you will, differently. And so, in fact, we were trained, we treat all people the same. Now, the spirit of that makes sense. It really does. However, everybody's needs are unique and individual. So I think shifting that, personalizing care, wrapping the right resources around that individual, everything and nothing more, but nothing less. That is, I think, where healthcare needs to go. And so that's a little anathema to many of us for physicians, because we think about treating everybody the same. But here's where it comes down to. If we treat everybody the same and the outcomes are different, we are doing something not right. Now, this applies to LGBTQ. That's why we created a very dedicated clinic, but it also ought to be applicable to the other groups that we talked about. We need to be willing to add personalized care and wrap resources around every individual. Now, again, that's an assumption of responsibility that healthcare has often said, not my job, but if it's not ours, then whose is it?
Thank you. There's another question about
so ultimately,
ultimately,
what I want to have happen is the way we do care and personalize that does become it's expanding. We've taken it out into other clinics. The follow-up visits are done at home clinics. And so those teams have now been trained and they're creating this safer space. So yes, what we want is this to become the way we always do it. But we don't need a dedicated LGBTQ clinic. That's our goal. Absolutely our goal.
Thank you, Kyle. So I'm going to skip around in the chat just because there's a question related to personalized care. So how have you changed or expanded the services and screening to go beyond biomedical needs specific to trans youth? So suicide screening, violence, need for job support, et cetera.
So I'm sorry, say it again. I was trying to look for that in the chat. Could you repeat that again? Sorry.
Oh, no worries. There's suddenly some more things that have landed in there, which is wonderful. So it was, how have you changed or expanded the services and screening to go beyond biomedical needs specific to trans youth?
So if I go down the wrong path, please let me know. Yes, we recognize that the care we provide for particularly, let's just kind of focus on transgender patients. It really is expanding ever quickly. And so we started with a lot of gender affirming hormone therapy, recognizing that the education that goes along with that as we work with our specialists, our colleagues, our peers, this idea of trans health, making this assumption that if someone is trans, then that means the other. So my child, sex assigned female at birth, must identify as a boy. Well, that is absolutely not the case. And so this idea of non-binary, this idea of gender expansive is really important that we really understand that notion, because a study from 2015 of trans folks, a full third overall identified as non-binary. When we looked at 18 to 25-year-olds, 60% of trans folks identified as non-binary. And so this concept of again, personalizing care becomes ever more important. And so it goes beyond this assumption that trans or gender affirming care is gender affirming surgery. It goes beyond this assumption that gender affirming care is again the non-natant hormone care. And so it really has to expand and become more personalized. So that's, I think, where we really have gotten is tools when we are taking care of our patients to personalize what are your goals of care, tools embedded now in Epic and electronic health records to do organ inventory So what parts, if you will, do you have that we still need to be screening for? If Epic or electronic health record is now triggering to your gender identity, it may not prompt us to look for cervical cancer screening, for example. So embedding tools to do the right types of healthcare maintenance and screenings has become the next step. And I think the newest thing that we're working on right now is a partnership to do gender affirming clothing. So gender masculine and non-binary folks often have triggering and gender dysphoria from chest. And so binders are a very common way to help combat that, but not everyone has safe access to binders, whether it's cost or perhaps even a parent or a partner that is preventing access to binders. So we have a partnership to create either free or low cost binders to our patients. And that's literally just getting launched next week.
Thank you. So there are a couple of questions that address engagement and driving change. So one is sort of from a more internal angle of how can I support and contribute to creating a more inclusive workspace or workplace. And then on the external side, what are strategies to drive change with active input from the LGBTQ+ community along the way, and how to make sure that everyone is in the room when decisions are being made?
Yeah, let's take the first. This is where leadership, I think, does play a role. So having a visible leader, especially in the C-suite, can make all the difference. And so if the leaders says DEI is important to us, it's important to us because we are responsible, a joyful responsibility for our workforce, for the community we serve, and for the patients that we serve. When we accept that as a joyful duty to take care, then DEI becomes just, again, an obvious part of that. And so creating that space, this is the vision, and this is what we want to be as an organization. But then underneath that, create the space for your workforce, your other leaders and team members to do their magic. So I think that's a 50,000 foot view, right? But it starts with setting that vision. And this is important to us. It's important to us because this is part of who we are. But also then we're all struggling, I'm sure everybody on this call, with workforce. Well, this is a workforce solution. This is an essential part of it, I believe. So finding joy, finding purpose, feeling seen and feeling known in my organization, but then also being engaged in a way that I get to create a difference. So as my leader, create a space where we need to be DEI inclusive, or better inclusive, go. And now your team gets to take care of that. So create a space after you set the vision. With regards to capturing voice, you'll never get enough. So I think the key for us was getting as much as we possibly could. And that for our community of 100,000 was, we have a university, and we have a Pride festival every year. So we had a listserv for that. And then we advertised some in-person settings, all before COVID, of course. And so I think we convened probably 15 listening sessions, as well as a listserv. But that continues to be something we constantly engage. We have a governing board for our committee, keep us on our toes. So always challenging us.
That's great, thank you. And more locally to you, Iowa has considered legislation to limit gender affirming care. How would that impact the care you are able to provide, and what can people do to support access to appropriate patient-centered care for transgender patients?
I have to be really careful with this, so I don't want to be. I don't think we should be political as physicians, but unfortunately, this has come into our arena, and so yeah, there are states already that have felonized the work that we do. That if I could be convicted as a felon, That has been talked about in the state of Iowa, but so far has not gone through. Last season, not the one that just ended, but last season, Iowa was worst in nation or most in nation for anti-LGBTQ laws that were brought up for review. None passed. A full 8 of them, so half, were anti-LGBTQ youth. And so again, during that time, what we saw our kids coming to our clinic, and adults as well, with increased risk for increased suicide ideation, depression, anxiety. It was extraordinary. I've never seen anything like it, really. 9/11 was probably closest to it in terms of the distress that people were feeling. So it does have an impact on health. I don't know what the answer is to this, but I think there's something that if AMA, AAFP, American Academy of Pediatrics, APA, if every major organization has, and they all have come out and said that gender affirming care is appropriate, it's right, it must be, we must have access to it. If all say that's the case, then a ruling of some sort, I'm not sure, changes the path forward. I think we continue to do the care rather than abandon patients.
Thank you. We recognize there's sensitivity there, so we appreciate you sharing your thoughts. And there's just over a minute left, so as a quick last question that I'll add on, do you think training around LGBTQ health will potentially become a requirement?
That's a great question. I've not heard that. I do know that just from the teaching that I do that it is increasingly becoming embedded into the curriculum. And so I think that medical schools are addressing this in a way that certainly wasn't present when I went through medical school. So I believe that it is becoming more mainstreamed into the curricular development.